Welcome to Research Perch from the Massage Therapy Foundation. Short, practical insights into massage therapy research and how it can benefit your practice.
Hello, everybody, and welcome to Research Perch. My name is Adrienne Asta, and I am proud to serve our industry through the presidency of the Massage Therapy Foundation. And if you listen to our last Research Perch, we had a really exciting guest, Dr. Cynthia Price, who taught us a little bit about the Mindful Awareness in Body-Oriented Therapy, or MABT. And this episode of Research Perch, we are really excited to have Kathryn Hansen, who works with the Vanderbilt University Medical Center in Nashville, Tennessee. Kathryn has massage therapy training. She is currently a nurse practitioner at the Vanderbilt Center for Integrative Health. In this role, she provides integrative health consultations and follow-up sessions, guiding and supporting patients as they walk toward achieving their health and wellness goals. Katie received her graduate degree from Vanderbilt with an emphasis in her education on palliative care, particularly in pain management. As a registered nurse, Katie worked in the intensive care unit of the hospital caring for critically ill patients. Prior to nursing, she earned her associate's degree from the Boulder College of Massage Therapy in Colorado and practiced therapeutic massage for 8 years. Her practice primarily worked with people having chronic and acute pain issues, including headaches, soft tissue injuries, and functional limitations. This diverse background informs and guides her holistic practice. Now, Katie had been awarded in 2021 our Massage Therapy Foundation Research Support Grant for the Mindful Awareness in Body-Oriented Therapy, MABT, for chronic pain and implementation science pilot study. So I want to say welcome to Katie Hansen. Thanks for being here today.
Wow, thank you, Adrienne. It is such a pleasure and an honor to be here. And thanks for sort of highlighting that background. I guess I would say, in relevance to this podcast, while my primary work was during the time I was a massage therapist, I also worked in a number of settings as a massage therapist. I worked in a chiropractor's office. I worked in an herbalist shop. I worked in a practice as an employee, a massage therapy practice, and then had my own private practice for a number of years as well. And I recently completed my PhD in health services research at Vanderbilt. And, my research emphasis is on the delivery of non-pharmacological therapies for chronic pain. And it probably isn't too hard to imagine, a lot of that grew out of my experience as a massage therapist. My own personal journey with massage therapy started actually when I was 17. I was in a car accident and sustained injuries for which I did not receive very helpful care, shall we say, from the healthcare system. And a dear close friend of mine at the time was a massage therapist. And that was really the only thing that made a difference for me. And I became very intrigued by this, ended up going to massage school. And, during my time in private practice, really felt like this work is so important. And I reached a point both where I felt like I wanted to learn more, but also just from a practical standpoint, I wanted to have health insurance, right? Like in private practice as a massage therapist, there's not a lot of benefits. There's benefits of making your own schedule. There's benefits of picking what you want to do and how you want to practice, which are phenomenal. I needed just some more sort of long-term stability from that standpoint. And now that I'm in the position and role that I'm in, I'm also the medical director at the center where we're at, where we've got an interdisciplinary team of nurse practitioners, psychologists, physical therapists, massage therapists, acupuncture, yoga therapists. I think a lot about how do we make this care more accessible to people. When I was in private practice, people had to pay out of pocket. And that both meant that some folks that didn't have great insurance would come and get massage instead of going to the regular healthcare system because they couldn't afford to. It also meant that more often that folks that could afford to get massage were getting massage when and so there were sort of some limitations in who I could serve. So going back to school partly for me meant being able to serve a wider range of folks because I could, wanted to be within an insurance billing model. Now that I'm in a position of trying to think about how we get as much of this care to patients as possible, I end up, when I think about massage therapy, some of the challenges that come up are how do we fit that type of care into more of a conventional medical setting? Not because not because it's any better or worse to be in that setting, but really from the access standpoint. Is that until we can provide better access to more people, there's always going to be sort of this disparity in who can access massage. And also because massage is so therapeutic that it really belongs as part of a treatment plan for so many different medical conditions, and there's so much to be gained in our conventional delivery of care by including massage therapy and massage therapists. This study came about. I first got interested in Dr. Price's work actually by listening to a podcast, and I was familiar with some of her work on interoceptive awareness. I've sort of been fascinated by interoception for a long time, and I reached out to her because we were on in the integrative health in the academic world is a little bit of a small world, and so I was able to reach out to her and start talking to her. And initially, I just said, "Hey, I want to be able to offer this in our clinic." There's such an emphasis in an academic health center on delivering evidence-based care, and so here was this protocol that she had gotten so much funding for and done such great work on, this 8-session protocol, largely looking at it in a substance use disorder population, doing these randomized controlled trials, and hey, she had good results. My interest was really in how do we take an RCT mind-body massage protocol and then actually access it, actually make it accessible to patients in the real world. What does that look like?
And that was something that that was emphasized with how we reported on your work, was that this is an implementation study. So for those of us who are listening who might not understand what an implementation study is, can you talk a little bit about that piece?
Yeah, I think very broadly you can divide the research world into sort of more of a mechanistic approach. Why exactly does something work? Which is better, 3 sessions or 5 sessions? Is it working on circulation or this inflammatory factor or what have you, versus more translational, pragmatic, and implementation research, which is what does it actually look like to deliver this in the real world? What are the modifications that you might have to make based on the setting and the population? Part of looking at implementation is figuring out what are the structural pieces that need to be there to successfully deliver the care. So I think most folks have been to a continuing education course where they learned a new thing, and you come home to your practice, and the next day, do you start doing that for every session all the time? Probably not, right? Because there wasn't implementation of that new piece into practice. So you have to have intention, you have to communicate it clearly to the people to set up for appropriate expectations. And then you want to evaluate, how did this go? Did people like it? Did they use it? So it's really about, it's really a pragmatic approach, which is something that resonates with me. When I was in my PhD program, my mentor kept wanting me to focus in, well, do you want to study massage or yoga or mindfulness? And I was like, no. I want to study the delivery of non-pharmacological care, because those things have more in common than they do different. I'm not interested in pitting one type of massage against another or yoga therapy against Tai Chi therapy. I want to know how best can we deliver those things. And that really is sort of what implementation science is all about.
Fantastic. Thank you for that. I think that's an important piece, because when we're talking about some resources that we have at the foundation, like the Practice-Based Research Network in particular, we're looking at implementation when we have those discussions in our PBRN, correct? Am I correct in saying that?
Absolutely. And there's a lot of work that needs to be done in this area, because most of our healthcare system is designed to deliver, I always say, needles and drugs, right? Needles, knives, and drugs. And when we're delivering non-pharmacological therapy, like massage therapy, the dose and the dosage are much more widely variable. When you prescribe one medication in Michigan and you prescribe the same medication in California, it's the same medication. And yet when we recommend massage therapy, well, that encompasses a huge amount of things. So we have to, get clear on what type of work, what are the goals of treatment, who's delivering it, what's their training, what's the payment model. There's a lot to be flushed out to be able to successfully deliver massage therapy. And my hope is, of course, that we're going to move towards more. And of course, in some states, they already are moving more towards more insurance reimbursement for these things. We've got to, help along the policymakers in knowing how many sessions should they be covering, for what types of conditions, etc.
Have you made any progress on dosing? I know we have a couple really small piloted dosing studies, looking particularly at immune response and stress response or stress hormone response and the effect on those two things. But I feel like there's so much more. And, where are we in the industry as far as the dose of massage? Because this is a practical question. Every single client who comes to me says, how often should I be getting massage? And I do the best I can answering that question, but man, it seems muddy.
Yeah, I think it's going to be muddy for a good long while, because part of it depends on, again, what your goal is. And it's a tool. So usually what I recommend to, for our patients, for example, is, you can go one time and improve interoceptive awareness, right? Get a different sense of your body. But I expect there's going to be a treatment plan. And is it to get rid of a particular pain? Is it to learn a particular skill set? It is, there's so many, is it to treat depression, right? We're having all these amazing studies that are coming out on mood. Well, how is that, like a medication, you keep taking it for it to keep working? Do we have to keep doing massage to have sustained benefit, or do we do a course of treatment and then we do boosters? I mean, all of that I would say is to be determined. What I would say about this study in particular, that what surprised me, I guess I would say, about some of the results is that I thought, an 8-session protocol is very common in mind-body interventions, whether it's a mindfulness skills class or a massage therapy intervention. And it's a little bit arbitrary, 8 sessions. So I thought in the real world that maybe people would do 3 or they would do 20, that people would not conform to the number of sessions. And actually what we found is that, we haven't finalized all of our analysis yet, but over 70% of the patients that had at least one session were completers of the protocol, which,
wow.
And this is part of the other thing about an implementation study that's significant is that and differs from a randomized controlled trial, is that people are paying for it. In a randomized controlled trial, there's a bunch of infrastructure to screen down so that only a very specific population goes with one specific condition. There's a bunch of things that get ruled out. You can't come if you're too depressed or you're too far away or what have you. And then it's free, right? You're getting this intervention for free. And so I thought when people were paying for it, and we were letting, it was, whoever got referred with all sorts of complexity to their conditions, that surely we wouldn't have as many people complete, or that they would use it differently than we expected. And so that was one surprising thing for me, was that even when people were paying out of pocket, and they were having to drive to the clinic and shell out their hard-earned money, that they were following essentially the 8-session protocol. Like there really was something to that structure, and they stuck with it.
That's amazing. Often finances are a barrier, right?
Yeah.
Part of the response I give to that question, how often do you come? And of course, I don't say it this tritely, but what can you afford, right? So,
right.
Right. The barrier of paying for it is certainly, and it changes how the client perceives the work also. So I'm really thrilled to hear that high of completion rate. That's thrilling to me, exciting. That's really exciting.
Well, and I think it shows what's possible. Like, I think for me, I think what some of my takeaway from that is we can't undersell ourselves and what we're offering to patients, right? Even within our clinic where we've had massage forever and we've had amazing massage therapists forever, we thought, oh gosh, well, people want to do this. And MABT is not your, feel good relaxation massage. People have their clothes on, they're being asked to do a really tactile facilitated mindfulness intervention. They have to show up and they have to work a little bit for it. And yet, when people have therapeutic benefit, guess what? They're going to keep coming. I mean, that's the reality, is that it becomes worth it, right? Like, it becomes affordable, for their time and resources. I will just say one more piece about affordability when it comes to healthcare. One of the confounding things that just I have seen over and over again in my time is that people, when I say, hey, you should try out this yoga class at our center, they're $12. And they'll say, is it covered by insurance? And if it's not covered by insurance, they're less interested. But they'll go and do the spinal injection that's covered by insurance. And then 3 months later, they're going to get a bill for $1,000, $2,000. And the success rate of those things is way lower and the risk is way higher, right? So it's really our idea of cost and what things are worth. There's a lot of layers in that.
How do you have a recommendation on how to communicate that concept, right? So one of the things I am careful about in my treatment room is I don't want it to be massage or medical care, right? I want to make sure that they are still getting the care that they need from their covered insurance care, if they need it. And there's not that much evidence to say, like, well, this is really a more efficient use of your money with longer term benefits, without getting too deep in the weeds. So recommendations.
What you can feel very empowered and clear about saying are that the Interagency Task Force for Pain and the American College of Physicians both recommend, among other various organizations and institutions, massage, acupuncture, mindfulness, yoga, a variety of other things, all before ibuprofen for chronic low back pain.
Awesome. Fantastic.
And then you can say the risk is very low, the potential for reward is quite high.
Excellent. And quality of life is high, right? Your quality of life is higher too. Tell me a little bit about your mentorship with Dr. Price. I'm curious to hear, someone who's doing these larger NIH research pieces and how that translates into the work that you're doing, and how does that dovetail?
Yeah, well, you can't have an implementation study without a more mechanistically researched intervention, and that's what she created. So what's been really exciting about working with her, obviously, like her level of experience, but also her insight, right? Her own story and background is so interesting because she has that background as a massage therapist and a psychotherapist, and then that PhD in nursing. So it's a really interesting combination. And she's sort of been there, done that in like thinking through a lot of the framework to be able to do this work well. And I think one thing that really drew me to MABT as an intervention is that what she is teaching clinicians, and then what those clinicians are facilitating with patients. In my experience of massage training, what she's teaching them is really what was distilled around cultivating presence, a therapeutic presence. And that's hard to teach. that's there. It's, you can get all of the right answers on the test. You can know the right medications or the right, different modalities or what have you. But being able to just like have a training that cultivates presence and awareness and safety, and then translates that in a skill set to patients to improve their somatic distress tolerance is, I think, just sort of phenomenal. And I think it's also really, she's really landed on a kernel of sort of mechanism that's probably present in most of our other mind-body therapies to some degree, right? Like part of what's happening is that people are having improvement in interoceptive awareness, improved interaction with that awareness. And she's created this amazing training. And I only wish that there was an army of people out there that could deliver it, right? Because that's where we kind of run into some barriers with, massage. Part of its richness is the number of different types of therapy out there and the trainings and everything else. And that's also partly what makes it so hard to use, right? As a healthcare system or a payer or an insurer is, can say, what am I really covering here? So the working with her has been an opportunity to take this amazing thing that she did and then, put it out there into the world and offer it to patients. And I would say something else that I have learned, I think, really because of her perspective, and because she is that sort of mechanistic NIH researcher brain, and I am, very pragmatic where I'm coming from, is that a lot of the things that we do in our clinic to deliver any mind-body intervention, we were doing with MABT, and she kept saying, why do you do that? Why do you that? Like her ability to be curious and ask, so you have to talk to the team every couple months about what's going on, or referrals drop off. And I was like, yeah, we do this for everything. And she's like, oh, well, that's really interesting, right? The idea that you're continually, essentially educating and having clinical conversations around how to best use. And like, are we going to send somebody to MABT, or are we going to send them to massage, or are we going to send them to mindful self-compassion class, and having those conversations about how best to connect patients with the right mind-body therapy, or the one that, it seems most appropriate at the time. That, her curiosity helped me to sort of realize how important that piece of it is. And she's just been lovely to work with. And yeah, so it's really been invaluable having her.
There's often internal debate in our industry about, why is it necessary to do the mechanistic piece when the interpersonal piece is such a huge component? And, I like that there's room for both. I think both are important and both make up what we do, because if it was just the interpersonal piece, we wouldn't have to necessarily touch them or do a thing, right? Or teach them a thing or lay our hands on them. And the mechanistic approach almost feels like we're a machine that presses this hard in order to get this piece. So I'm loving that this type of research, like the stuff that you're doing, it's really showing the blend nicely of really, it's the gold that massage therapy is. And certainly all of the other non-pharmacological approaches to care. Is there opportunity for seeing how, because you talked about, which mind-body therapy might be right for this particular patient? Is there opportunity to see these are the top 3 things that we can do in conjunction with each other for this particular patient? Is there opportunity there? Is it far away? Is it using too much energy to think that far out, right? So, is it the let's not try to science this to death because we're losing the art of it?
Yeah, all of those things are true. I would say there's there's truth in every different, rivulet of what you just defined. And I would say that I don't think that it's ever going to be as simple as these top 3 things, because it really depends on the individual and what their goals are. Some people just don't like to be touched. Some people, we sent them to MABT because they tried a mindfulness class first and they couldn't, it was so uncomfortable for them to just sit there. Their mind was going too fast. They were too off in space. And we actually found that MABT for people where mindfulness was challenging was actually it seemed to land better, anecdotally and clinically, because it was one-on-one and it was tactile and it was facilitated. Some people are just going to do better with a tactile intervention, right? And in the future, it would be, I think that there is room for these multi-component interventions and for picking which one when. But at the end of the day, even if tomorrow every insurer in the country said we are going to cover massage therapy and we're going to pay everybody $150 for a 60-minute session once every 2 weeks for the rest of their lives, first of all, there wouldn't be nearly enough massage therapists to do that. And secondly, if we said, but we're only going to cover, John Barnes myofascial release, or we're only going to cover MABT, or we're only going to cover this one, up ledger craniosacral, or these, like individual things, then we're really missing out, because these are therapies that will be delivered at a zip code level. So I'm less interested in which one of those is the best. I don't want to do a trial that compares the, 3 most common, I don't know what you would call it, like post-education certifications, continuing ed trainings, right? I don't want to do a comparison and say, which one's the best? Okay, that's the best one. Everybody should do this one. Like, no, because the interpersonal is important. If somebody is living in a town and they have a really good, Essalon massage person, and then, 3 towns over, they have a really good myofascial release person, you're still better off going to those folks than not, even if the therapy doesn't perfectly align. Does that make sense?
Yes.
Like, it's not yoga or Tai Chi. If there's only yoga in your town, then it's yoga, right? And so within that, though, what are the standards? What are the expectations? What is the level of training and experience, right? I've now been, doing, hands-on work. I often say I should get a business card that says touching the place that hurts for the last 25 years, and, we know that there's a huge arc of development that happens with experience over time. So, when people say what type of massage I should do, I'm more likely to say, find somebody that has at least 5 years of experience. If you've been able to stick around for 5 years, then yeah, you probably have a diverse enough skill set that you can navigate whatever comes. Because a lot of when I'm making recommendations for massage therapy, it's usually not just for general wellness. It's people with really complicated health issues. They've had 5 back surgeries. They've also got PTSD. They've also got migraines. They've also got, XYZ. And so, while any massage might potentially be beneficial, I'm less likely to point them to a particular therapy than a particular level of experience.
Got it. Yeah. Anything else in the results that you'd like to share with us besides the 70% completion?
Mm-hmm. Let's see. I'm trying to think of things that were, I would say, because this is a mixed method study. So we had surveys and we also did focus groups. And the importance of having the schedulers and the administrative team understand and be able to speak to MABT versus regular massage was really, really important. And, I don't think that we would have had the amount of follow through that we had if patients, because this is a novel thing, right? It's new. It's, most patients that show up, they don't walk into my office and say, can I please have therapy for improved interoceptive awareness? That's not what they say when they show up, right? Mm-hmm. And you even say the phrase interoceptive awareness and they're like, huh? So, you have to find a way to way that people can sort of latch on to this. And we do that maybe when we're talking with folks as clinicians and making a referral, but a week later, when they get the phone call to schedule, they may or not remember much of that, right? There's a study that said that they interviewed people in the parking lot after their primary care visits, and they only remembered 50% of what was said. So the value and the importance of having, the scheduler, the administrator, the person on the phone that to say, hey, oh yeah, this is different than regular massage. This is to work with, on distress tolerance or your symptoms related to chronic pain. Them being able to build that bridge was just hugely important. And we have seen that play out in some other clinics around campus that have tried to implement more novel non-pharmacological therapies. They've fallen flat, not because there's not demand, not because there's not benefit, but because that translation of, hey, maybe you should try this, doesn't make it through all the different layers that it needs to in a large healthcare system to landing to that patient showing up that day for that session. Does that make sense?
Yeah, for sure. For sure. Yeah. And as you were saying that, I'm thinking about, our massage therapists on the front lines who are running their own practice and doing their own booking and things like that, and the importance of all of the pieces, not just the piece in the treatment room, but the communication and the interaction prior to them even stepping foot into your building. And then of course afterwards, and how they're doing, and the follow-up is such a huge piece of that. And that's a beautiful example of why we should care about those pieces of getting the client to you and making sure that they understand the goals and the need and what we're going to deliver, the expectations.
Yeah. Can I give you one more that just popped into my head?
Please. Okay. Yeah. Give me as many as you want.
Another thing that I think was really profound. So, a lot of this is, these stories that come out of these experiences, we have a team of psychologists, and there was maybe a little bit of not resistance, but sort of curiosity around these massage therapists that are holding space in this way for patients for 8 sessions. They were won over. I will just say that, there's definitely a lot of value. They realized that there was a lot of value, and the massage therapist did such a beautiful job of holding that scope of practice, right? So staying focused on what we're doing in the moment. And when things sort of stepped outside of that, referring it to the psychologists, right? Like, oh, that's something you should work on with your therapist if, trauma stuff arises, what have you. But we had, one of the stories was somebody that had, been in psychotherapy for a long, long time, as many people have been, and did some of the MABT therapy and was able to make significant progress that they had not made before because of what the skills and that improved awareness of their own experience allowed them to make progress in these other areas where they had previously been stuck. Amazing. And the massage therapist wasn't doing the psychotherapy, right? But we know we can't separate this stuff. And there is such a, unfortunate and tragic gap between being able to, be close to someone and be therapeutic and then actually physically, therapeutically touch them, right? Therapists don't often feel comfortable touching people. I would say in nursing, yes, we touch people all the time and we're usually poking and prodding people, not necessarily doing, having like therapeutic reassuring touch. So there is just something that I don't think can be replaced by any machines or any type of other therapy besides actual, grounded, safe, therapeutic touch. And the importance of that being able to exist in an interdisciplinary team, I would say it's also something that comes out of that. Like if we don't have massage in an interdisciplinary setting, we're missing out on a really important piece.
For sure. It's almost like there's a nice transition then. It's not almost like there is a nice transition. And a conversation I have with a lot of my referral partners, right? Physical therapists and personal trainers, acupuncturists and chiropractors. We all do some level of stretching, let's say. Let's kind of take something as simple as stretching. And one of the personal trainers that I refer to had said like, oh, I'm sorry, I hope I'm not stepping on your toes. And I feel like, no, like that's the bridge for them to come from me to you, right? You know, instead of like, here, you're going to do this. Now we're going to step over to this section and here you're going to do this where it's broken. The beauty of the non-pharmacological approaches is that it's whole, right? It's whole person. And I feel like these are the little components where we could almost, you know, literally pass the baton, right? So now here's the deeper work. And we touched a lot on the scope of practice stuff with Dr. Price on the last Research Perch podcast. So if you want to listen to that, please just look at our April 11th episode of Research Perch for more on that piece. So I really appreciate that you brought that to our attention on this episode as well. It dovetails really nice with Dr. Price's from a month ago. Anything else? Any other little nuggets that anything that I'm not asking that I should ask?
You know, one thing I will say that is a challenge that I have that I'm just going to put out there to the massage world that I would love other perspectives on is the challenge of how we get more massage therapists onto these interdisciplinary teams. And I will say that part of the challenge in my experience is that being in private practice is a pretty good gig. You make your own hours. You only do as many sessions as, you know, in the conventional setting, there's, you know, sort of a higher expectation of meetings you have to go to, of documentation, you know, numbers. You know, you're an independent contractor. If you're an employee, yes, you get the benefits of health insurance and everything else, but it also means that there's vacation time. There's just more, you know, more of the bigger system stuff that you have to deal with. A lot of people became massage therapists so they wouldn't have to deal with that stuff, and I understand it. I'm really like, you know, I always sort of joke that I aspire to get back to my private practice as a massage therapist, because you pick and choose who you see, right? In a setting like ours, somebody else is doing all your scheduling. And not that there's people you don't want to see, but boy, when you're seeing really challenging, complex people all day, every day, it's a little bit different. And we have a model that's a throughput model, right? So you don't necessarily get to keep your same people forever, because otherwise we wouldn't get to have new people come in and do this interdisciplinary team thing. So I will say one of the, you know, and actually, you know, one of our massage therapists that we trained in MABT that was a part of the study, since the study has ended, went back into private practice and is doing MABT in the community and charging twice as much, and he's full, right? So, you know, which is great. I don't think that's in some ways it's not a loss, right? Because he's doing the work and people are accessing it. It is, it's just challenging. So I would just, you know, it's something that I struggle with. Again, that tension between the, all of the amazing diversity that's out there in terms of different types of therapy, and then how do we get folks to come in and work within a system? And I think I don't know if there's something from an education or schooling standpoint, or if we make more massage fellowships to train people in sort of, you know, more of this model, or what, but I would just love to find a way that works for massage therapists, right? That's nurturing for massage therapists, but also allows our conventional healthcare system to have more of that integrated.
Awesome. Thank you. If someone wants to get in touch with you, how do they do it?
Probably email is best. I don't know if you have like a little, I can give you my email. I can put it in a tag for this episode, maybe.
Yeah, we'll do it in the show notes for sure. So
cool.
If you are part of an organization that does research, please feel free to check out massagetherapyfoundation.org and see all of the granting opportunities we have for research for massage therapy and body work. Katie, thank you so much for your time today. I'm so thrilled with the work that you're doing. And I'm certainly looking forward to seeing what comes next for you and for our industry because of the work that you're doing. Appreciate you so much.
Thank you, Adrienne. It's been a real joy spending time with you today. Thanks.
If you enjoyed this podcast, please consider donating to the Massage Therapy Foundation so that we can continue to bring you this and many other resources to increase your knowledge and improve your practice. Thank you.